Today's topic is approach to patients with end-stage heart failure. There are a lot of cases which is climbing up day by day, and we know that non-communicable diseases is a reality, and it's kind of getting worse than cancer in every country in the world. So we're going to deal with this in this manner. When I asked the postgraduates as to what they want from this discussion, they said they would like to know some of the basics, functioning of the heart, pathophysiology of heart failure, management of heart failure, palliative care and evidence basis, what we'll speak last once we understand the pathophysiology, and we'll summarize it at the end. Okay, just a bit of anatomy early in the morning. So we're all familiar with this from our anatomy classes. It's just to remind us. Let's see. Okay, so this is the right atrium, the left atrium, right ventricle and left ventricle. There is a connection between right atrium and right ventricle, which is the tricuspid valve, the left atrium and the left ventricle, which is the aortic valve. And from the left ventricle rises the aorta. It goes and divides. From the right ventricle climbs the pulmonary artery. That also divides. And the superior vena cava and the inferior vena cava, as you can see, drains into the right atrium. And into the left atrium, we have the pulmonary veins. So we have the oxygenated blood on the left side, and we have the deoxygenated blood on the right side. A little more elaborately. Okay, we can see. Let's take from the left ventricle. We can see the blood goes through to the aorta. It goes up, circulation to the tissues in the head and upper body. Then aorta divides, and we have a descending aorta, and that circulates to the tissues of the lower body. And from the right ventricle, we have the pulmonary artery, which goes to the right and the left lungs, as you can see. Blood gets collected from the lungs, from the different parts of the body. From the different parts of the body.
Shobha, just a minute. Shobha, can I interfere? Because the voice is little louder, please. People are given a comment in the chat box. Little louder, please.
Little louder. Okay. Can you hear me now?
Yeah.
Can you hear me? Yeah. Okay. Is it better?
It's fine now. It's fine.
Okay, fine. All right. So you can see that in the lungs, oxygen gets collected, carbon dioxide is given into the tissues, whereas the opposite happens in the different parts of the body, where carbon dioxide gets collected and oxygen is released. So we have a general understanding of how blood circulates in the body. Okay. So before we go any further, let's look at the causes of heart failure. So beginning from high blood pressure, poor blood supply to lungs, lung problems, lung disease, asthma, bronchitis, obstructed airways, high blood pressure in the lungs. And you have other medical conditions like anemia, kidney disease, diabetes, obesity, disordered breathing during sleep or sleep apnea, thyroid disorder, side effects of medications. And then you have other infections which affect the heart, like rheumatic fever, Chagas disease, not seen in our country. Lifestyle, failure to take preventive medications, diets, excessive salt or fluid intake, alcohol or drug misuse. And you have heart problems, valve defects, rhythm disorders, heart muscle defects, other disorders of heart, and coronary heart disease. So everything that happens in your body ultimately can affect your heart. Okay, so then this can lead to heart failure. Now, when we talk about pathophysiology, the heart, I think every organ in our body is adapted to the onslaught that we give to our body. Even if we abuse our body, it has a miraculous way of recovering itself I think our creator has that inbuilt in us that we recover, the cells recover. The cells either die, replaced with a new cell, or they recover their function and function as before. But when it becomes too much, when it crosses a limit, that's when things go haywire. So you have these overwhelmed adaptations which can lead to heart failure. So what are they? Let's have a look. So you know the Frank-Starling mechanism, which has increased preload, uh, that can help sustain the cardiac performance. So we'll come to Frank-Starling mechanism in a minute. So these are the adaptations that a cardiac muscle has to cope with the onslaught. The alterations in myocyte regeneration and death, myocardial hypertrophy with or without cardiac chamber dilation, in which the mass of contractile tissue is augmented. And then we have activation of neurohumoral systems. Each of these is so important in maintaining our cardiac cycle. So, Frank-Starling mechanism, which we studied in physiology many eons ago, okay, which has stroke volume and the left ventricular end diastolic pressure correlation. So, there is an optimum pressure point wherein you have the optimal stroke volume. You have left ventricular end diastolic pressure, which forces blood from the heart, which is the stroke volume. And that is optimal. So when the venous return increases, that means when the preload increases, as you can see here, you can see that the stroke volume also increases. So what happens here? So we would have studied in physiology that the sarcomere, the muscle fibers extend, and as soon as you extend it, the tensile strength, you have more energy to contract. So the inotropic effect increases. So there is a lot of mechanism in this physiological pathway which causes this basically, and calcium plays a major role in this contraction. So when there is an increased pressure in the left ventricle, there's an increased venous return, because of which the pressure increases, you have an increased stroke volume. And vice versa happens when the preload is reduced, when you have decreased diastolic pressure, stroke volume reduces. So our heart adapts to the pressure and it gives out the maximum stroke volume that it can. Okay. And then there are alterations in myocyte regeneration and death that happen. So you have the heart muscle here, you have structural adaptations in gene regulations, and you have hypertrophic cardiomyopathies. It could be eccentric hypertrophy or concentric hypertrophy. Okay, so let's look at the mechanism. So hypertrophic agonists, the sarcomere mutations can happen, cytoskeletal mutations, valve regurgitation, ischemia, systemic hypertension. All this favors hypertrophy. And what are the multi-scale responses that can happen? So mechanosensitive gene regulation, myocyte remodeling, myofibroblast activation, the extracellular matrix restructuring, and ventricular remodeling. So there are a lot of pathways, a lot of interconnected things happening, which restructures the heart. And the pathological phenotypes are dilated chambers and systemic dysfunction, which is dilated cardiomyopathy, hypertrophied walls, reduced chamber volume, diastolic dysfunction, and this can lead to fibrosis. So you have hypertrophic agonists like valvular regurgitation, ischemia, hypertension, cytoskeletal mutations, etc., and you have multi-scale responses. And then you have pathological phenotypes, which is either dilated cardiomyopathy or hypertrophic cardiomyopathy. I think this slide is very important. I think we need to give some time to concentrate on this slide. I think half a job is done if we concentrate on this slide. Okay, are you all with me?
Yeah, Shobha, madam.
Yeah.
Participants are not being able to hear you clearly, I think. Is it possible to increase the volume a bit more?
Okay, let me see. Is this better?
Little better, yes.
Okay. I'm just holding
थोड़ा सा
my mic.
खुल के बोलना पड़ेगा शोभा, आवाज सच्ची में कम आ रही है.
Oh, okay. Right. This is going to be a technical problem. Okay, is that better, Arun?
Yeah, better, but you continue at this voice. At the end of the speech, the voice goes down.
Okay, all right. Okay. So this slide is very important, as I said earlier. So we'll focus for some time on this slide. So what does it say? We would like you to focus on the compensatory mechanisms on it. So you know that there's myocardial dysfunction, there's reduced stroke volume, reduced cardiac output, reduced blood pressure. So obviously, our different end organs are underperfused. So we need to increase the volume, increase the oxygenation into these areas. So compensatory mechanisms kick in. So what are these compensatory mechanisms is what we need to focus. So you can see that when the BP reduces, the carotid sinus and iliac arch baroreceptor activation happens, and there is increased ADH release, antidiuretic hormone. So there is arginine vasopressin receptor activation, and increased water retention happens in the renal collecting ducts. Okay, so that's one area by which the body copes. And then we have the most important RAS system, which is the renin angiotensin aldosterone system. Nothing works without this, so extremely important. It reduces blood pressure, increased release of renin from the juxtaglomerular kidney cells due to renal hypoperfusion. So you can see in that macula, the Bowman's capsule, the afferent and efferent arterioles. So in the efferent arterioles, as it reaches the Bowman's capsule, you can see this juxtaglomerular cells from where renin is released. Now, renin, can you type it in the chat box? Where does renin act? Or on what substrate does renin act? Let's have a little bit of questions in between. Anyone?
There is a question for the audience. Where does renin act in the body? Yes, someone has written. You
Yeah.
can. Yeah.
So what is the answer? I'm not reading it, Arun. So
Okay. Okay.
yeah.
ACT2 receptor, angiotensin 2 receptor.
So sorry,
Angiotensin 2 receptors. That's what people say.
angiotensin 2. It acts on a substrate. Before
Yeah.
angiotensin 2 is synthesized, it has to act on a substrate for angiotensin 2 to come.
Angiotensinogen.
That's right. Absolutely brilliant. Okay, so where do you find angiotensinogen?
Participants can speak up if they want.
Yeah, you don't need to type it in. You can speak if you want. Where do you find angiotensinogen in the body? Just to recall of our physiology days.
Okay, they've written endothelium, but what endothelium?
So,
Lungs.
mm, any other answer?
Not yet.
All right. Oh, liver, absolutely brilliant. Whoever wrote that. Okay. So liver is the organ which secretes angiotensinogen. So it is there in the blood. It's circulating in the blood. So when renin gets released into the blood, it acts on the angiotensinogen, right? And then it converts it into angiotensin 1, basically. And this angiotensin 1 is converted to angiotensin 2 by our angiotensin converting enzyme. And this is where we can inhibit this enzyme and control when the system gets overwhelmed, to control the pressure and things like that. So this is very important. Angiotensin 2, which is synthesized from angiotensin 1 by the angiotensin converting enzyme, acts on the adrenal glands to release aldosterone. And it acts on the renal distal tubules, wherein sodium and water retention happens. So sodium reabsorption and water retention happens. Okay, so this is the RAS system. There's a lot of things connected with this. We'll come to one by one in a minute. Okay. And then we have the sympathetic nervous system. So in response to the reduced cardiac output, sympathetic nervous system increased release of catecholamines, as you would know, norepinephrine and epinephrine, which acts on alpha receptor activation and beta 1 receptor activation. So alpha 1 is basically found in blood vessels of different organs, not in the muscular blood vessels. Okay, because we want muscles to receive blood when there is cardiac contraction. So alpha 1 basically is found in different blood vessels in the body except the muscular blood vessels. And then you have beta 1 receptor activation, which is mainly located in the heart. There is contractility of the heart increases, which is through the sympathetic nervous system. So what happens here? So alpha 1 receptor, when that acts, you have the heart activation of the blood vessels, where there is peripheral vasoconstriction, increased systemic vascular resistance happens, okay, in alpha 1 receptor. In beta 1, there is chronic beta 1 receptor activation, where there's calcium overload, myocyte apoptosis. You know, in movies, in older movies at least, you know, they used to show that there is a very bad news coming into the household, and suddenly somebody clutches their heart and collapses and dies, you know, because of the trauma. And it's actually possible for that to happen. Sorry. And because the calcium overload, there is toxicity and there's absolute tight contraction which is not released, and people can die quickly. Okay, and if you look at the maladaptive responses in this section, the lavender colored area, you can see that there is increased preload, so that there is increased stroke volume. So there is more blood into the systemic and pulmonary area. And when the maladaptive systems sets in, when there is overwhelming of the system, you have congestion of this area, because there is more and more blood pumped into this area because of the Frank-Starling mechanism. And then the other things that happens is increased resistance against LV ejection. So there is reduced stroke volume. There might be, you know, afterload increase in this when there is peripheral vascular resistance. So there's reduced stroke volume. And the other remodeling, when that happens, there is reduced contractility of the heart. And there is reduced coronary blood flow and myocardial ischemia that happens. So the whole lot of systems, it's like a web which is interwoven, and without one, the other can't function. So it's a very intricate mechanism of contractility. So, and then the physical signs and symptoms of congestive cardiac failure happens when there is maladaptation of the system. Okay. Now, when we talk about the sympathetic nervous system, there are other important pathways which plays a major role in the cardiac function, and the maladaptation of which can cause cardiac failure. So one such substrate is endothelin 1, which is secreted by the endothelium of blood vessels. So what happens is when there is shear stress, that is a little bit of rupture because of the plaques in the blood vessels, when there is hypoxia, when there is catecholamines, angiotensin II release into the body, endothelin is secreted from the endothelium of the blood vessels. And then what happens? It acts on the kidney and on the heart. So on the kidney, it again stimulates the adrenal gland. There is increased aldosterone, there's sodium and water retention, and there is intravascular volume increment. Okay, so there is reduced sodium excretion, reduced glomerular filtration rate, and renal efferent vasoconstriction. So the artery which comes out of the Bowman's capsule, there is a constriction there. There's more of water available for filtration in the Bowman's capsule, and there is the efferent vasoconstriction happens, and the absorption is reduced, and there is more intakes of sodium and water retention. That's what I meant. Okay, so on the heart, you have increased arterial vasoconstriction, you have increased sympathetic activity, and hypertrophy of the heart muscles can happen because of endothelin 1. There's increased systemic vascular resistance and then reduced cardiac output. So there is a balance which is going on. So endothelin is an important substrate in cardiac function. And the next such important function is done by nitric oxide angiotensinogen system. So we said that angiotensinogen is acted upon by renin, and then you have angiotensin 1, which changes to angiotensin 2 by the ACE inhibitor, which acts on 81 receptor, angiotensin 1 receptor, and you have this ARBs, angiotensin receptor blocker, basically angiotensin 1 receptor blocker. Angiotensin 2 receptor is also there, but that action is different. So angiotensin 1, we have vasoconstriction, salt and water retention, and remodeling happens via angiotensin 1 receptor. Through angiotensin 2, we have anti-proliferative cell differentiation and tissue repair in angiotensin 2. Okay? Now, we should also never forget there is another pathway where the kinins, the angiotensin converting enzyme, basically kinins, and it also acts on bradykinin. Okay? And that degrades into inactive degradation product, or it can act on the bradykinin 2 receptor, which releases nitric oxide, again a vasodilator. So you have, on one side you have endothelin 1, which is a vasoconstrictor. On the other side you have nitric oxide, which is a vasodilator. So vasodilatation, natriuresis, and anti-remodeling. So the delicate balance of all these things is very important in maintaining the cardiac cycle. So nitric oxide, angiotensin interplay happens here. And the next most important, as we all know, is natriuretic peptide system. So whenever a patient comes with cardiac failure, we always tend to measure BNP, the B-type natriuretic peptide. Okay, so all these are present mostly in the heart muscles. Some of it are present in the periphery as well, and some of it in the brain. But the ANP and BNP, as you can see, okay, the sympathetic nervous system, you can see here, the ANP and BNP, angiotensin 2, again, you can see that it releases ANP and BNP. So that means nitric oxide is also released by stimulation of angiotensin 2, and atrial natriuretic and B-type natriuretic peptide is also released by angiotensin 2. So what does it do? It increases natriuresis, reduces blood volume, reduces aldosterone secretion. So that is vasodilatation, reduced blood pressure, increased endothelial permeability happens with ANP and BNP. And if you look at angiotensin 2, again, that is the reverse of what ANP and BNP does. There is vasoconstriction, increased blood pressure, increased endothelial permeability also happens. Increased sodium intake, increased blood volume, increased aldosterone secretion in the kidneys, and hypertrophy and fibrosis in the heart. So very intricate balancing mechanism happens in the body. So far we talked about different systems that helps in maintaining the cardiac cycle, of which the RAS system, the sympathetic nervous system, and the antidiuretic hormone system is very important in adaptation and remodeling and reshaping the functioning of the heart. And along with that, endothelin 1, nitric oxide, and the natriuretic peptides also play a role. Okay. Now, we all know the signs and symptoms of heart failure. I'm not going to go through this list in detail. We know that there's exertional dyspnea, 2, S3, gallop, and or pulses alternate. So I'm sure the postgraduates will be presented with the slide, so maybe you could go through it leisurely, or you could read textbooks which are available. Okay, so signs and symptoms. Now, we need to know about Framingham criteria. The fact that there are 2 major or 1 major and 2 minor criteria, which is the diagnostic indicator for heart failure, in the sense, okay, paroxysmal nocturnal dyspnea, 2 radiographic cardiomegaly are major criteria, and nocturnal cough, 2 bilateral ankle edema are 2 minor criteria. So if you have 2 major or 1 major and 2 minor criteria, this points to heart failure. Again, I'm not going to read the list, which is all self-explanatory. Important classifications that we should know: New York Heart Association classification, class 1 to class 4. Class 1, no limitation of physical activity, whereas in class 4, symptoms occur even at rest, discomfort with any physical activity. ACC, AG staging system, extremely important. This is where our treatment is based. Stage A to stage D. Stage A, high risk of heart failure, but no structural heart disease or symptoms of heart failure. In the next slide, we're going to focus on this in detail. So I'm not going through each stage at this juncture. Right. So I think we need to spend some time on this slide. Okay. So we talked about stage A to stage D. Stage A, at high risk for heart failure, but without structural heart disease or symptoms of heart failure. Okay. These are patients with hypertension, atherosclerotic disease. So heart failure, there's no structural abnormality. Let us remind ourselves. There's diabetes mellitus, obesity, metabolic syndrome, or patients using cardiotoxins. Cardiotoxins could be anything from alcohol to chemotherapy, therapeutic agents, with family history of cardiomyopathy. And so what is the therapy? The goal of stage A disease would be healthy lifestyle, prevent vascular coronary disease, prevent LV structural abnormalities, and the drugs that can be used are ACE inhibitors or ARB in appropriate patients for vascular disease or diabetes mellitus, basically, as a preventive thing for future macro and micro vascular complications. We could use that, okay? And statins is appropriate. So stage A then moves on to stage B, where there is structural heart disease, but without signs of symptoms of heart failure. So, which category of patients belong to this? These are previous MI patients, LV remodeling, including LVH, and low ejection fraction. So what is it? What is the normal ejection fraction?
Question to audience. Can anyone tell us the normal ejection fraction? Yeah, chats are coming in 60%.
60%. Okay. So how do you calculate ejection fraction? Anyone?
How do we calculate? Neetu and Vikas, can you also tell how we calculate? You can talk, I think. You don't need to write and heart rate into stroke volume.
Heart rate into stroke volume?
Yeah, that's what they say.
Okay, ejection fraction is basically depending on the left ventricular diastolic volume and the stroke volume. Of course, that is it. So whatever is there in the heart is not going to be completely pumped out. There's some amount of it remaining. So that is why we say 60%. So otherwise, ejection fraction would have been 100%, isn't it? So the stroke volume per stroke volume is the blood that comes out with every stroke, isn't it? That's about 70 ml, which is normal. The cardiac output is stroke volume into what is it? What is the normal cardiac output? Anyone? Normal cardiac output?
Normal cardiac output. 5 to 6 liters.
5 to 6 liters. Excellent. So the ejection fraction is around 55 to 60 is absolutely right, because the whole amount of blood in the left ventricle cannot be pumped out. So it's the difference between the stroke volume and the left ventricular diastolic volume, which is expressed in percentage. Okay. So what is the therapy? So when people have had a previous MI, the goal would be to prevent heart failure symptoms, prevent further cardiac remodeling, and the drugs would be ACE inhibitor, ARB, or beta blocker as appropriate. Some patients might require ICDs, implantable cardioverters or defibrillators, cardiac defibrillators, and revascularization or valvular surgery as appropriate. So this is where stage 2 is where you kind of tend to think on all those extra fittings, so to say, or maybe revascularization. So as we move on to stage C, there is definitely structural heart disease with prior or current symptoms of heart failure. So in stage B, there was no signs or symptoms of heart failure. As in stage C, you have structural defect and signs and symptoms of heart failure. These are like patients with known structural heart disease and HF signs and symptoms, which is already there. Now here, for long, people have been talking about systolic and diastolic dysfunction and also cardiac failure, right-sided, left-sided cardiac failure. So the latest classification is heart failure with preserved ejection fraction and heart failure with reduced ejection fraction. And the preserved ejection fraction is basically why do we differentiate? I think when we talk about nausea and vomiting management in palliative care, we always try and find out what is the pathophysiology, because for each different cause, the treatment is different. The same way here, depending on the pathophysiology, the treatment is different. So the goals for heart failure preserved ejection fraction would be control symptoms, improve health-related quality of life, prevent hospitalization, prevent mortality, and the strategies would be identification of comorbidities. So preserved ejection fraction, we have comorbidities to take care of rather than what is happening inside the heart. Okay, so what are these? So diuresis to relieve symptoms of congestion and the guidelines to control hypertension, atrial fibrillation, coronary artery disease, diabetes mellitus, etc., etc. So the preserved ejection fraction type of heart failure focuses on this. Whereas with reduced ejection fraction, again, the goals are similar. The drugs for routine use, diuretics, ACE inhibitors, ARB, beta blockers, aldosterone antagonists, steps in here in research, because there is a lot of remodeling happening here. And drugs for use in selected patients, hydralazine, isosoprodinitrate. Now, what happens is when there is reduced ejection fraction, the coronary vasculature supply also gets affected, and then you need to find ways and means to actually, maintain that in a normal manner. So sometimes you need to add in hydralazine, isosoprodinitrate, etc. Digitalis is another medication that we would add in at this juncture in these patients. We'll talk about digitalis a bit later. In selected patients, the cardiac resynchronization therapy, ICDs, revascularization can happen, like when you thought about all these in stage B. Now, we move on to stage D, wherein the patient has marked heart failure symptoms at rest, recurrent hospitalization despite guided medical therapy, guided medical therapy. These guidelines determined medical therapy is GDMT, okay, guidelines determined medical therapy. So what happens is recurrent hospitalizations, even with prior adjustments of ACE inhibitors, beta blockers, etc., in the past few months, they've had repeated admissions. And of course, they categorize themselves as stage D. So therapy goals are control symptoms, improve the health-related QOL, reduce hospital readmissions, and establish patients' end-of-life goals. This happens in stage D. So probably by default, this is where we step in. But is it enough if we step in here, or is it good if we step in before? Is a question that we might have to answer in order to set up palliative care in heart patients. Okay, so what are the options that is available for stage D patients? Advanced care measures, heart transplant maybe is available. I mean, it can be made available, not easy. Chronic inotropes, that means people are on continuous infusions with dopamine, dobutamine, or milrinone and those kinds of medications. Temporary or permanent MCS, which is the cardiac synchronization mechanical cardiac synchronization measures, experimental surgery or drugs, palliative care, hospice, and ICD deactivation. Okay? So stage A to stage D, we've kind of an overview of what happens with the goals, with the treatment plan, etc., etc. So we move on from here. So far, we've been talking about anatomy of the heart, pathophysiology, different classifications of heart failure, and how do we manage each stage. Okay. So, having said this, let's move on to management of heart failure. Arun, are you keeping a track of the time, please?
Yeah. It's 7:11. We
Yeah.
have
Okay.
around 10 minutes with us.
Sorry.
We have 10 to 15 minutes with us.
Okay, fine. Okay, so anything and everything in palliative care begins with non-pharmacological management. So here you can see that, of course, you need to encourage physical exercise. I mean, tuned physical exercise for heart failure patients. You can stop taking alcohol or in moderation. There's some sound disturbance. If people can mute themselves, that will be fine. So reduction of alcohol, stopping smoking, and if you're in the habit of taking any sort of recreational drugs, then we can, ask them to stop that. And of course, weight check and regularization of body weight is very important in maintaining your cardiac function. Dietary sodium should be restricted to 2 to 3 grams per day, and fluid restriction to 2 liters per day, which is recommended. Evidence when there is evidence of hyponatremia, there's less than 130. Fluid state is difficult to control despite sodium restriction, and use of high dose diuretics. Okay. Now, there are some 7 or 8 points which we need to concentrate on if we have to get on top of the pharmacological management. So reduce morbidity and prevent complications is what we need to do for these patients. So the first and foremost group of drugs which does this is diuretics, which reduce edema by reduction of blood volume and venous pressures. That is furosemide, torsemide, bumetanide, hydrochlorothiazide, metrelizine, blah, blah. And the mineralocorticoid receptor antagonists, spironolactone and eplerenone. Can people mute themselves, please? Because there's some disturbance in the speaking system. Okay, spironolactone and eplerenone. And then comes vasodilators for preload and afterload reduction, where there's nitroprusside, hydrazine, nitrates. And we were talking about the natriuretic peptides, or BNP. Synthetic BNP is available, which is nesiritide. So I've just written the name nesiritide. There are also other drugs which inhibits the pacemaker, eye pacemaker in the heart with a funny current, with IF inhibitor, which is evergreen. The importance of evergreen is that it doesn't affect the contractility or the heart rate. I mean, the lucitrophy, the contractility, which is the inotrophy, and the lucitrophy, which is the relaxation bit. So it doesn't have any effect on that, but it definitely reduces the heart rate. Evergreen. So that acts as an added-on medication in this family of medications that people have. Okay. And the next most important group is the angiotensin receptor neprilysin inhibitor. Now, what is neprilysin? Neprilysin is the inhibitor, is the enzyme which degrades BNP and ANP. Okay. So when we need BNP and ANP in more concentration to vasodilate and to prevent heart injury. So this combination is found to be useful. There are plenty of trials, there are plenty of cardiac trials which happens with different combinations of drugs. And when they use BNP, the enzyme inhibitor, the NC enzyme inhibitor, which is neprilysin inhibitor, alone there was not much of a use. So they've started using combination. They found that this is useful. So that's the second group of medications. And digoxin, which can cause a small increase in cardiac output. Like I said earlier, digoxin, it improves the contractility, and it also helps in relaxation. It's a cardiac glycoside, but it it doesn't adversely affect the lucitrophy and the chronotrophy of the heart rate. So adversely affect. So it is used in a correct dose, and we need to be careful because most of these patients might have renal problems. So digoxin toxicity can happen easily in this group of patients. So inotropic agents which help in to restore organ perfusion and reduce congestion is milrinone, dopamine, and dopamine. And anticoagulants decrease the risk of thromboembolism. Beta blockers for hormonal modification, arrhythmia prevention, and ventricular rate control. Carvedilol, bisoprolol, metoprolol. Now, bisoprolol is very specific beta-1 selective. Carvedilol is a broad spectrum beta-1, beta-2, and alpha-1 blocker. So bisoprolol is mostly preferred. You have angiotensin converting enzyme inhibitors, and of course we can't forget analgesics for pain management. Along with with that, it also decreases the preload in the heart failure and relieves dizziness. So a certain group of medications is what we looked at. Now, what is the statistics? In India, non-communicable diseases, 60% of adult deaths. Cardiovascular is 25% of those deaths. Again, in India, of all deaths, cancer 79 per 100,000, and of all deaths, cancer 6% of all deaths. This is cardiovascular deaths alone. Okay. And in US, mortality following hospitalization for patients with heart failure is 10.4% at 30 days. At 1 year, 42.3% at 5 years, despite marked improvement in medical and device therapy. So it is a major problem, is what we can see. So we've talked about generally heart failure so far, okay? And now we'll step into the familiar territory. So need for palliative care in heart failure. So update is given this chart in which a kind of table in which there is criteria for palliative care assessment. So what is the criteria? Potentially life-limiting. And we always have this surprise question whether they'll be alive within 12 months or not. Do they have frequent admissions? Admission prompted by difficult to control physical or psychological symptoms, complex care requirements, decline in function, feeding intolerance, failure to thrive, etc. Admission, the secondary criteria, admission from a long-term care facility or medical foster home, which doesn't happen so often in our country. Older patient, metastatic or locally advanced cancer, chronic oxygen use, out of hospital cardiac arrest, current or post-hospice program enrollees, and limited social support or no history of completing advanced care planning. So these are all probably US and US based, basically, not even UK, because they have this insurance system working there. So very important. So we know that when there is poor prognosis for any sort of disease, we would prefer palliative care. When there's high symptom burden, again, palliative care, lack of communication. They need communication. If the patient and their relatives and the treating team needs somebody to help with the communication, of course, we step in. And prognostication of heart failure, extremely difficult. When there's initial presentation, people present with heart failure, and then they stabilize themselves for a long time, then there are decompensations happening. And you can see the palliative measures happen, like in cancer, from the very beginning. This can also help. There are immense number of studies which shows that there is benefit, but what is the level for the evidence is what we need to discuss. We'll come to that in a minute. So there are different tools, as you can see, difficult prognostication. This is for the postgraduates to just know that there are different models and different tools available, of which the Seattle heart failure model that you can see, and meta-analysis global group in chronic heart failure score, which is a risk score, is the most commonly used, very well validated in different settings. Okay, just to cast an eye on Seattle heart failure score, there are umpteen number of variables which helps in a proper analysis of the situation to say whether the patient is going into stage C, D, or whatever that is. Okay? It is there on the slide. Now, what is the evidence of palliative care? What is the evidence for palliative care measures in heart failure groups? So, in US and Europe, a lot of studies are there. It says that is level 1C. And what is level 1C? Strong recommendation. There is strong recommendation, but there is low quality evidence. That means we ourselves are not producing that evidence. So evidence from observational studies, unsystematic clinical experience, or from randomized controlled trials with serious flaws. Okay, that's not properly conducted. So any estimate of effect is uncertain. Estimate of effect is uncertain, obviously, and that is why there is low quality evidence, but there is strong recommendation. So you're referred a patient with end-stage heart failure. How will you proceed? Okay, so obviously we're going to take a history. We're going to look at the comorbidities apart from heart failure, what is contributed to it, etc., etc. And then we will first focus on symptoms. So what are the main symptoms that these patients can have? Dyspnea, pain, depression, and fatigue is what I've listed here. There are umpteen other symptoms which we'll talk in a second. Okay. Dyspnea. Now, this particular paper, I've given all the references at the end. This particular paper, this person has made his own classification. So this is not according to evidence-based. It's guided by the evidence-based classification, but this makes sense. So I've just put it here. So class 1, what he means is loop diuretics with or without thiazides, nitrates, and low dose opioids. There is strong evidence for this, and it is recommended. Class 2A for dyspnea, inotropes, aquapheresis, which is ultrafiltration, walking aids, breathing training, exercise training. There is some amount of evidence, and it is recommended, is what you mean by class 2A. Now, class 2B, oxygen without hypoxia, there's absolutely no evidence, but we still give just for placebo effect. So there's no, it's unreliable. The evidence is unreliable, and this is class 2B. Now, class 3, what he says is sometimes this can be harmful. So benzodiazepines in dyspnea, in cardiac failure, other than panic attacks, this sometimes can be detrimental, can be harmful. So you need to actually, if it is like related with COPD, you have COPD patient going into heart failure, maybe you have panic attacks, and those patients, it might be helpful. So you need to be extremely careful when you deal with symptoms in cardiac failure. What about pain? Now, we need to understand that there's generalized pain. There could be bone pain in these patients, and there could be angina. So again, a lot of evidence for opioids, bisphosphonates, nitrates, beta blockers, calcium channel blockers, and there's another drug called ranolazine. If you look at the cardiac prescription, you might come across this medication because this is given for angina, because it acts on late sodium channels in the cardiac cycle, and it inhibits calcium and sodium influx into the cells, so that there is no contraction, and it gives relaxation to the muscles, especially the coronary vasculature gets relaxed, and blood supply to that area happens, and there is less pain, angina pain. Okay? Class 2B, some evidence but not conclusive, acupuncture, exercise training, music, etc. Okay? Class 3, which is detrimental, you're not supposed to use NSAID for pain, as we all know, this increased sodium and water retention. So what about depression? SSRIs, SNRIs. So citalopram, sertraline, fluoxetine, I've put it in brackets because this has got a lot of drug interactions with different drugs. As such, these patients are on different drugs. And if you are providing palliative care, you might have to give morphine, you have to give laxatives, etc., etc. Lots of different interactions with fluoxetine. So generally not preferred. Citalopram is probably preferred in SSRIs. But they say that SNRIs are a much better choice because of lesser side effects and an improved pain control with digoxin. This is something which we commonly give for patients in SNRIs. Tricyclic antidepressants, which we don't use because of the fear of QT prolongation arrhythmia, but they say imipramine or nortriptyline can be used. Class 2A, CBT, counseling, supportive therapy, exercise, some amount of evidence. There's some amount of evidence in the sense it is controversial. So whether exercise can help in depression, we're not very sure. And there is insufficient evidence for acupuncture in depression. So what about fatigue? This is extremely important. This is another symptom which happens in cardiac patients. Class 2A, treat secondary causes. Anemia, infection, sleep apnea, stimulants, methylphenidate. Have somebody used methylphenidate in your practice? Do people use methylphenidate in your practice?
Yeah, please put in the chat box. Just to be sure of the time, we have 5 more minutes.
Yeah, Srikanth has raised his hand. Yes, 5 minutes, it will get over. And exercise, increased rest and reduction of physical activity. Insufficient with NSAIDs. So fatigue, NSAIDs, again, this is a little bit of controversial area where can we use this in cardiac patients. Nutrition supplements, appetites and stimulants, etc. Other symptoms, edema, ascites, constipation. Constipation is major in these patients, I would say, because there's hepatic congestion, there is intestinal vasculature congestion, there is ascites, and people go in constipation, you can treat constipation as you would normally do. And nausea and cachexia is important as well. Pentoxifylline, thalidomide, etanercept, statins, all these are immunomodulatory agents that is used in cardiac cachexia, just for your information. So please read up about it. We cannot forget the pediatric population, but most of the time we get consultations for pediatric population for goals of care or psychosocial support. But there is a role for symptom management in this population as well. So what is you've looked at the symptoms and you have generally managed the symptoms. You have the patient is feeling a bit better. Maybe you've just started a morphine infusion. It's a miracle drug, and patients start feeling better with that. So what are you going to say to the relatives? So we need to obviously assess the level of understanding. Even if the prognosis is not certain, there's no excuse. That means you need to speak to them. How do we prepare? You can tell them what to expect, what time frame roughly. You can explain scenarios. We are supposedly good at this, so this doesn't need a lot of contemplation at this juncture. So we can talk about the preferences. Is there another person who you would appoint? This doesn't normally happen in our country because there's a lot of collusion, and it's the relatives who take the responsibility. What are the goals of treatment, DNI, DNR, location of care, deactivation of ICD? You know, people are so attached to their cardioverters and other ventricular devices that they are reluctant to switch it off or understand the importance. So it's a tough conversation that we are going to have. And of course, we can plan for the worst, help them to plan for the worst in the sense financial assistance, emotional support, community and family support. All this we are experienced and trained in, so we will do that. Now, there's an interesting paper which, or a commentary which came in JAMA in February 2020, wherein the authors, I couldn't find out whether they were palliative care physicians, but by the looks of it, they look like cardiologists. They said that palliative care should be integrated as routine care for patients with HF. And most importantly, what they said was PC and prognosis in heart failure should be de-linked. It should not be coupled together. Okay, so if there is prognosis bad, you call the palliative care physicians. That should not happen, is what they said. And promote PC education with both patients and physicians. Very tough scenario. Okay, so what is the summary? We talked about complex compensatory mechanisms. We talked about multimodal therapy, non-pharmacological and pharmacological management. We talked about the PC needs. Obviously, we need communication skills is very important. We need to control the symptoms, and we can help in prognostication and talk to the treating team and help with some amount of rehabilitation or end-of-life care, whatever the case may be in such patients. So, what is the way forward? Can we have an action plan? Maybe all those people who are working in institutions are not standalone kinds of care facilities could approach the cardiology department, maybe take up a research project, recruit stage D patients for palliative care. Can we have a multi-centric trial? I think Sushma would be the best person to, facilitate that. Thank you for your kind attention.
Thank you. Shall we go for the questions? We have 3 questions in the chat box.
Okay.
Yeah. So thank you again for covering the, it's a big topic. Thank you again for covering and sticking to time. So first question is hyponatremia in heart failure needs to be corrected, especially if patient is disoriented or lethargic. It's a question.
Say that again, Arun.
So hyponatremia. The question is, shall hyponatremia in heart failure be corrected, especially if the patient is disoriented or lethargic because of hyponatremia?
Yes, of course, it needs to be corrected because at the end of the day, we are looking at normal concentrations of sodium and not lower concentration of sodium in cardiac failure. Yeah. So definitely that needs to be corrected, yes.
Thank you. Next question is, please explain oxygen without hypoxia in the management of dyspnea and the role of paracetamol in the management of pain. Okay, we can go for the first question, oxygen without hypoxia.
So oxygen without hypoxia, when people just keep it because the people are having dyspnea, they are breathless, but the saturation is normal. And what would people normally expect? They want their oxygen mask on their face. So the patients would expect that, the relatives would expect that, but there is no evidence that if there's no hypoxia that giving oxygen is going to be of any help. We sometimes do it because of the placebo effect that it has when the patient requests. Otherwise, they would say, oh, the doctor you didn't even put an oxygen mask on me. So there is no evidence whatsoever if there is hypoxia that you need to give oxygen to such patients.
Yes.
So what was
Yes.
the next question? Yeah.
Thank you. So next question is how to deal with anorexia in CHF patients.
So, so like I said, the cachexia anorexia syndrome, and it's a whole topic on its own. Maybe we can schedule that topic on its own, because there are a lot of medications and trials which is happening, including thalidomide, including pentoxin, like I said earlier. Statins, which is again immunomodulatory, whether that can improve the cardiac cachexia and the lean mass and the fat mass and things like that. This in turn, if you immunomodulate, that inflammatory responses come down, and that in turn can improve your appetite. So it's a whole different topic on its own.
Yeah, it's 7:31. So I was wondering if Sushma Madam wants to take over.
Yes, thank you very much, Shobha. I know, as Arun says, it was a big topic, but you have covered it very well, right from the anatomy, physiology. I think everybody, it was a good revision.